Welcome to our video on diabetes and macrovascular disease presented by Dr. Veron Yala. Our presentation will have 4 points: an introduction, the mechanism leading to macrovascular disease in diabetes, some trials, and we'll summarize. Diabetes is a worldwide pandemic disease with significant mortality. The International Diabetes Federation in 2015 estimated that 5 million people died from the disease, and this number is expected to increase to 642 million people living with diabetes by 2040. High blood sugar, known as diabetes, results of either absence of insulin production in type 1 diabetes or not enough production of insulin by the pancreas, with the inability to be used by the body in type 2 diabetes. Chronic hyperglycemia or chronic high blood sugar damages your large and small blood vessels, known as micro and macrovascular complications. We'll be more talking about macrovascular complications. But what are the microvascular complications? We have nephropathy, retinopathy, and neuropathy. The main macrovascular complications are ischemic heart disease, peripheral artery disease, and cerebrovascular disease. When we compare diabetes patient to non-diabetic patient, they have fourfold greater risk for cardiovascular event. And the risk for first MI is fivefold greater and twofold greater for recurrent MI. The International Diabetes Federation in 2015 in Europe estimated 59.8 million people suffering from diabetes, while this number will increase to 1.1 million. And in Africa in 2015 it was 14.2 million, while this number will increase to 34.2 million. The risk factors for cardiovascular disease, according to the American Diabetes Association, is hypertension, dyslipidemia, smoking, family history of premature coronary disease, presence of protein in your urine. These are the risk factors: smoking, high blood pressure, dyslipidemia, with narrowing of the artery. Micro and macrovascular complications are drawn in this picture. We can see on the right inside of our presentation that are microvascular complication: diabetic retinopathy, nephropathy, neuropathy. And the macrovascular complication, we have stroke, heart disease, and peripheral vascular disease. The main mechanism leading to macrovascular disease: chronic hyperglycemia with other factors that we have stated before causes atherosclerosis, which is the hardening of the artery due to formation of the plaque inside called atheroma, which occludes the lumen of the artery. We can see here a plaque forming in lining of artery on the first one. And in the second one, how it grows with time when all the risk factors they are not managed in a good way, they are not controlled until it occludes completely in the fourth picture, causing a limitation or a decreased blood flow to the main organ that are supplied by the artery. We have three different organs that are affected when the atheroma is formed in the artery. We have the brain, the heart, the limbs. In this picture, we can see how an atheroma has caused a damage in an area of the brain in this patient, causing stroke with a facial droop that the patient is presenting. In the following picture, this patient has a crushing chest pain, and this is due to an involvement of the coronary artery causing damages on the heart and different symptoms that result from damages of myocardium. In this picture, one of the limb has been affected and causing a gangrene. Four trials will be mentioned: the UK PDS, ACORD study, ADVANCE, and VET. The United Kingdom prospective study, larger trial conducted in UK, enrolled 5,102 patients, which aim whether improved blood glucose would prevent complications of diabetes and whether there are differences between diet and pharmacologic intervention. Outcomes: the HbA1c, which is the 2 to 3 months average of your blood glucose, was reduced to 7% in intensified therapy group, while it was 7.9% in conventional therapy group. And they find reduction of microvascular complication by 25%. But the reduction of macrovascular complication, MI, and stroke was not significant over 10 years period. This UKPDS picture shows tight glycemic control reduces complications. With 1% of HbA1c reduced, we have 21% of death related to diabetes that are reduced. And 1% reduction of HbA1c will reduce 14% of heart attack. 1% of HbA1c reduction will cause 43% of amputation of fatal peripheral artery disease reduction, and the stroke will be reduced by 12%. In the ACORD study, which stands for the Action to Control Cardiovascular Risk in Diabetes, enrolled 10,251 type 2 diabetes patients with cardiovascular disease or additional cardiovascular risk factors. Two groups were studied: intensive therapy versus standard therapy groups, and the study aimed to achieve a HbA1c of less than 6%. The study was stopped earlier in 2008 due to an increased mortality in intensive group over 3 years and a half of follow-up, and the study didn't find a reduction of non-fatal MI, non-fatal stroke, or death from cardiovascular causes. In Advance in 2008, it enrolled 11,140 patients with two groups studied: glycoside-based intensive regimen versus standard group based on local guidelines, and they found that both macrovascular and microvascular disease were reduced in intensive group. In the Veterans Affairs Diabetes Trial, enrolled 1,791 military veterans and mean age of 60.4 years. Two groups were studied: a group on metformin plus rosiglitazone versus group of glimepiride plus rosiglitazone, and no difference was found in the incidence of stroke, cardiovascular death, congestive heart failure, and myocardial infarction. This table summarizes hardcore, advanced, and vet. We can obviously see that in terms of significant effect on macrovascular outcome, none of them showed a positive outcome. In this picture, we can see 5 trials or studies: the DCCT, UKPDS, AID-CORD, Advance, and VET. The DCCT was done in type 1 diabetes. In the UKPDS, what we can mention here, that initially the cardiovascular disease event in both groups studied, there were no difference. But in a long-term follow-up, we can obviously see that there was a reduction. In terms of mortality, there was a reduction in long-term follow-up, while there was no difference in initially. In the VET, is same as UKPDS. Initially, no difference. Reduction in long-term follow-up. Mortality, no difference in initial trial and long-term follow-up. In both AID-CORD and Advance, no difference were found in initial trial and long-term follow-up, while in AID-CORD, the increased mortality was found in 2008. That is the reason why the study was stopped earlier. In summary, what we want you to understand is how to reduce your risk of developing macrovascular disease. Healthy lifestyle means healthy food, physical activity or exercise, quit smoking, treatment. There is a target of HbA1c that you need to achieve. Treat different risk factors when they are present. Healthy lifestyle by healthy diet. You need to talk to your dietitian for better guidance. Plan with a dietitian on which food you must eat, you must take according to the risk factors that you're having. If it is hypertension, for instance, you will need less salt intake in your food. But we must remember one thing. As mentioned by the American Diabetes Association, that medical nutrition delivered by a registered dietitian decreases HbA1c by 0.5 to 2% in type 2 diabetes. And also, HbA1c reduced by 1% will reduce the development of macrovascular complication by 35%. It's very important. Physical activity. There are many benefits due to exercise. We'll recommend you to exercise 150 minutes or more per week. The benefit due to exercise, we have improved blood glucose control. It will reduce your cardiovascular risk factors that we have mentioned above, contribute to your weight loss, improve your well-being. If you are smoking, consider quitting. If you can't, find a healthcare provider who can help you. But do you know also that smoking have an increased risk of cardiovascular disease, premature death, and macrovascular complications? Treatment. There is a target of HbA1c that you need to achieve. According to the UKPDS in 1998, they gave an evidence that more intensive glycemic control in newly diagnosed patients may reduce long-term cardiovascular rate by 16%. We recommend to individualize the HbA1c as mentioned by the American Diabetes Association. Less stringent target should be aimed in patients with long duration of diabetes, advanced atherosclerosis, advanced age, an HbA of less than 8%, that is good. More stringent glycemic control may be considered if this can be achieved without significant hypoglycemia, less than 6%. But commonly what is recommended universally is less than 7%. Treatment of risk factors. You have your hypertension, you must take your high blood treatment. Be compliant to the treatment. Take your treatment as recommended by provider and aim for a blood pressure of less than 140 of over 90. If you are having bad cholesterol, what we call dyslipidemia, you must lower your level of cholesterol. You must take your lowering lipid agent. Talk to your provider who will prescribe to you according to the risk that you're having. The blood sugar, are you on tablet or insulin? Take them as they are prescribed by your provider. Thank you for following this video.